Welcome back to the podcast, everyone. Today, Dr. Sarah and I are diving into a concept that is essentially the bridge between the brain's intention and the body's action. We are talking about the motor unit. Imagine you're at a concert. You have the conductor waving the baton, and you have the musicians playing the instruments. If the conductor points to one violinist, that's a very specific instruction. If he signals the entire brass section, that's a different level of volume and power. That relationship, that specific link, is what we are breaking down today.
That is a great way to frame it, Dr. Khan. For our students and those preparing for their board exams, we need to be very precise with the definition. A motor unit is defined as a single motor neuron and all the specific muscle fibers it innervates. Note that I said single neuron. This is the functional unit of the neuromuscular system. When that one neuron fires, every single muscle fiber in its group contracts simultaneously. It's an all or none game at the unit level.
And that all or none part is huge. But let's get into the why does this matter clinically almost immediately. Think about the difference between your eye moving to read a book and your leg moving to kick a soccer ball. If the eye used the same wiring as the leg, your vision would be jumping all over the place. It's all about the ratio, right, Sarah?
Exactly. This is a very high-yield concept for exams. The size of the motor unit determines the precision of the movement. In muscles where we need incredible fine-tuned control, like the extraocular muscles that move your eyes or the small intrinsic muscles of the hand, we see very small motor units. We're talking maybe 5 to 10 muscle fibers per neuron. It's like having one manager for every 5 employees. There is a lot of oversight and precision.
I love that. One manager for 5 people is a boutique operation. But then you look at the heavy lifters like the gastrocnemius in the calf or the gluteus maximus. These are the stadium movers. One motor neuron there might be responsible for hundreds, even 1,000 muscle fibers. It's a massive shout rather than a whisper. Clinically, this is why a small injury to a nerve in the hand is so much more devastating to daily function than a similar injury to a branch in a large postural muscle. You lose that boutique control.
That's a vital clinical point. From a board perspective, you also need to know where these neurons live. The cell bodies for these somatic motor neurons are located in the anterior gray horn of the spinal cord. If you see a question about a lesion in the ventral horn, that's the same thing. You are looking at a direct hit to the motor unit's command center. This leads us to lower motor neuron signs, which are always a favorite for examiners.
And when those command centers in the anterior horn get hit, like in cases of poliomyelitis or even localized trauma, what do we see at the bedside? We see the 3 A's: atrophy, areflexia, and atonia. Why? Because if the neuron dies, the muscle fibers it talks to are effectively ghosted. They stop receiving signals, they stop exercising, and they waste away. Being the doctor of choice for your patients means being able to look at a wasted muscle and immediately think, is the problem in the muscle itself, or did the motor unit's neuron quit its job?
Let's stick with that. When we test reflexes like the patellar reflex or knee jerk, we are actually testing the integrity of this whole circuit. We're tapping the tendon, sending a signal to the cord, and asking the motor unit to respond. For the boards, remember the levels: C5, C6 for the biceps, L2, L4 for the patellar, and S1, S2 for the Achilles. If the motor unit is intact, the muscle jumps. If it's damaged, you get nothing.
It's like testing a light switch. If the bulb doesn't turn on, you have to check the bulb, the wire, and the breaker box. The motor unit is the wire and the bulb. Now, Sarah, tell them about recruitment, because our bodies don't just use all these units at once, do they?
No, and that's a sophisticated piece of physiology. It's called Henneman's size principle. Your body's efficient. It doesn't want to waste energy. When you pick up a feather, your brain only recruits the smallest, most excitable motor units. As the load increases, say you're lifting a heavy textbook, the brain starts recruiting larger and larger motor units to provide more force. It's an orderly addition of power.
It's like a dimmer switch that slowly clicks into higher and higher brightness settings. If we didn't have this orderly recruitment, every time you tried to sip a cup of coffee, you'd punch yourself in the face with the force of 1,000 bicep fibers. Clinically, we see issues with this in certain neurological disorders where muscle tone is lost. Dr. Sarah, how does the book define muscle tone in this context?
The book describes muscle tone as the constant slight contraction of a muscle, which is maintained by the low-frequency firing of different motor units in a staggered fashion. Even when you are relaxed, some of your motor units are on call to keep your posture. If you lose that, the muscle becomes flaccid. This is a huge clue during a physical exam. A floppy limb tells you there is a break in the reflex arc or the motor unit itself.
Exactly. So to wrap this up, why does this matter for the future physician? Because the motor unit is the final common pathway. Whether the brain is planning a symphony or a sprint, it all has to go through that one alpha motor neuron and its specific family of fibers. If you understand the motor unit, you understand why a patient with a nerve injury has a different type of paralysis than a patient with a stroke in the brain.
Great summary. Just remember for your exams, one neuron plus multiple fibers equals one motor unit. Small units for precision, large units for power. Lesions in the anterior horn mean the motor unit dies, leading to atrophy and loss of reflexes. That is the high-yield core of the musculoskeletal nervous system interface.
And that is our deep dive into the motor unit. Keep thinking about those orchestras and conductors next time you're in the anatomy lab or seeing a patient in the clinic. We'll catch you on the next episode.